Hi everyone, my name is Iris Hunt and I'm an L2 medical student at LSU Health Sciences Center in New Orleans, Louisiana. The title of my project is The Timing of the Glasgow Coma Score, Documentation in a Trauma Database, Implications for Patient Care, Research, and Performance Metrics. My mentors for this project were Dr. Anthony DeGeorge from the Neurosurgery Department and Dr. John Hunt from the Trauma Surgery Department. The objectives of this project was to look at how the timing of collection of certain information may improve or detract from the accuracy of models trying to explain clinical severity of injury or disease. For this project, we used the collection of the Glasgow Coma Scale, or GCS, which is an objective, reliable measure of a trauma patient's mental status. As you can see from this chart on the right, the GCS uses eye-opening, verbal, and motor responses to develop a quantitative score with a maximum of 15 and a minimum of 3. And so our study looked to determine the contribution of timing of the GCS to the performance of commonly used risk adjustment tool for trauma patients. We took trauma registry records of consecutively admitted patients with blunt trauma during a 4-year period from 2013 to 2017. And we further parsed this to include only patients with traumatic brain injuries, which is a GCS below 8. We excluded penetrating trauma and patients who were discharged from the emergency department. The GCS documented during the trauma resuscitation will be known as GCS1, and the GCS documented during the initial neurosurgery consult will be known as GCS2. From these two metrics, we were able to calculate the change in GCS. Also, with our two GCSs, we were able to calculate the patient's probability of survival, or POS, using the Trauma Injury Severity Score, or TRIS method. This was done once using GCS1, which gave us probability of survival 1, and then we calculated it again using GCS2, which gave us probability of survival 2. We were then able to compare the probability of survival 1 and the mean of probability of survival 2 to the cohort's observed rate of survival. In our final cohort, we had 454 patients. And what we found was that the mean of GCS1 was 6.69, and it significantly differed from the mean of GCS2, which was 7.84. If you look at these two top tables on the right, you can see that GCS1 was more heavily influenced by patients who had a GCS of 3, which sort of accounts for these results. In regard to change in GCS, 180 patients had no change in GCS, 70 patients had a decreasing GCS, and 204 patients had an increasing GCS. From this GCS data, we also found that according to GCS1, 72.69% of patients had a severe TBI, and as noted by GCS2, 63.44% of patients had a severe TBI, which again is a GCS below 8. So after calculating our two probability of survivals from our GCSs, we found that the mean of probability of survival 1 was 74.7%, and this was significantly different from the mean of probability survival 2, which was 79.3%. Our observed survival rate for the cohort was 71.0%, and when we compared this observed value to the probability of survival 1, probability of survival 1 was significantly greater, where the p equaled 0.004. When we compared the observed value to probability of survival 2, we found that probability of survival 2 was increasingly significant, with a mean of p less than 0.0001. So in conclusion, we found that GCS1 recorded on patient emergency department arrival differed significantly from GCS2 recorded by the neurosurgery team at later times. Probability of survival 1, and therefore GCS1, was more closely correlated with patient survival. GCS is used in many different metrics that impact aspects of patient care, including risk-adjusted benchmarking, assessments of quality care, and injury severity stratification of research. So more research into the optimal timing of GCS reporting or how changes in GCS have an impact on survival is definitely warranted. I hope you enjoyed it. Thank you.